It's a really pleasure to be again with Young. It's nice to see so full room of people attracted by interesting program. My topic is more practical, itinerary to bifurcation PCI. And last year I had privilege to be in the same room with one of my mentors, Dr. Colombo. This year I'm with another mentor, Professor Marco. Whatever I learned about sharing education, I learned from Professor Marco, and I want to personally thank him for all that he did for all of us. My lecture will be actually comprised by combination of evidence, and also we try to move education to the next level by inserting resource saving and resource tailoring in everyday practice. Because people from different parts of Europe and the world come here to Paris course on revascularization, and for some of them, of course, resources are not critical, but for some, like people in Egypt, I've been there a couple of weeks ago, it's extremely important to plan procedure, and I want to have your attention, and please go to Eurointervention and look for these two articles. I think these are complementary evidence that you may need in your everyday practice. As Dr. Milashinovic said in the beginning, our topic is to discuss planning and executing bifurcation PCI. And most of procedures, at least according to current guidelines, actually recommend provisional side branch stenting strategy, which does not preclude use of the second stent. And you saw images of 3 bifurcation lesions in 3 different vessels. What we believe since the beginning of European bifurcation club formation since 2004 is that if you want to preserve and protect the side branch, you should put wire in the beginning in both vessels, main branch and the side branch. And wiring of the side branch before main vessel stenting is recommended also whenever you deem side branch is important by the operator. And you can find in the other articles some of the aspects with the traffic light system. For what we have evidence, we put in green. So upfront side branch wire is recommended in true bifurcations, or if difficult rewiring is anticipated. In red, we say what we should not do. So putting wire only in the main branch is not recommended if side branch osteum is severely diseased or unfavorably angulated. And in yellow, we put something that we can modify, discuss, and try to maybe save some of our resources. So you can use only main branch wire if side branch angle is favorable and if no severe disease is present at the ostium of the side branch. Second step is predilatation. We usually recommend predilating main vessel if it's fibrotic, fibrocalcific, but we don't routinely recommend predilating side branch ostium, especially if lesion is not diffuse and if it's not calcified. A reason for not routinely predilating is that mechanism of balloon angioplasty is plaque rupture and creation of dissection planes at the ostium of the side branch. If you do it before main vessel stenting, then you create multiple dissection planes inside that plaque at the ostium of the side branch, and following main vessel stenting, when you try to recross those dissection planes, increase the likelihood of proximal re-entering. And if you re-enter proximally, you can go in one of those dissection planes and you can expand dissection and compromise the flow. So it's something to be discussed. If you think that disease is diffused or it's severely calcific, of course you will predilate because you are planning upfront not to stent side branch, but maybe if you need, it's better to prepare that lesion in the beginning. And again, you can find that main branch predilatation is good for facilitating optimal stent expansion. And when performing side branch in red, side branch predilatation, it's not recommended to use the same balloon as in the main branch unless main branch and side branch are compatible. Side branch predilatation only if flow is impaired, side branch access difficult, or if there is diffuse disease and calcified lesion. Next step after predilating the main vessel is to select the stent. And you saw in presentation of Dr. Milashinovic the difference in diameters between the proximal main vessel and distal part of the main vessel actually helps you decide what size and the length of stent should be taken. We believe that if you take stent according to proximal main vessel diameter, you simply, because of discrepancy in diameters, create carina shift, you push carina inside the ostium of the side branch and you compromise the flow. So we believe you should intentionally select stent according to distal main vessel diameter. In that case, you will decrease the chance of having carina shift from the beginning, but then you need to be aware that your stent is grossly underexpanded proximally. And to do that, you need to know difference in diameters proximally and distally, but of course you need to know your devices. And I want to point your attention to paper of Nicolas Foin in International Journal of Cardiology 2016, in which he compares maximum expansion capacity of currently available drug-eluting stent platforms. So you can know that, for example, left main was discussed in a previous presentation. If you want to select a large stent, then probably only Resolutonics can achieve with extra large vessel platform maximum of 6 millimeters, but then you can also use the Synergy 4.0, which can be expanded up to 5.7. Again, we say that drug-eluting stent is recommended for bifurcation treatment, but it should be sized according to distal main vessel reference diameter. And of course, we don't routinely recommend, if we decide to use planned two-stent strategy from the beginning, we don't use two bare metal stents because of high recurrence rate, restenosis, and possible stent thrombosis. However, if you work in part of the world when you need to save the resources, you need to use only bare metal stent if it's the only one available bare metal stent, but in that case, you should try to use it as a provisional strategy with very meticulous post-stent optimization, with proximal optimization, distal optimization, probably even opening of the struts towards the side branch. And when we come to optimization, because of the difference in diameters proximally and distally, we use short, non-compliant balloon which expands stent and recreates natural fractal geometry of bifurcation. So inside the tube, inside the stent, you actually have, like in nature, proximally big diameter, distally smaller diameter, and wide open access into the side branch. So proximal optimization was introduced by Dr. Olivier Darmon from France and now becomes routine part of the procedure. Why POT is so important? Because look this cross section here. If you use stent according to distal main vessel diameter, here is floating stent in the proximal part of the main vessel. So you take short non-compliant balloon, not to go outside the stent, you put distal marker of that balloon in front of the carina, and by inflating that balloon, you actually expand with a higher proximal diameter stent in the proximal main vessel. And in that case, you will have one bigger diameter proximally and one smaller diameter distally. And we have data from clinical studies now. It's a COBIS registry in which use of proximal optimization had impact on clinical outcome, and MACE rate was reduced compared to no POT. And of course, there was no difference in mortality, myocardial infarction, or stent thrombosis, but there was difference because of better expansion in target lesion revascularization with significantly lower revascularization inside the main vessel stent, which is really important for clinical outcome of our patients. After proximal optimization, next step is routine final kissing, and there is a question whether we should do it routinely in provisional, as well as we try to promote it in two stent techniques. Our consensus is that kissing balloon inflations may be used when angiographically significant, more than 75% diameter stenosis or TIMI flow less than 3 exists at the ostium of the side branch after main vessel stenting. So we really need to have very tight lesion angiographically, or we need to have flow compromise. Why final kissing balloon inflation is important? You are aware that by overlapping two balloons in the proximal part, you increase diameter and you expand stent better in the proximal part of the main vessel. So the major benefit of final kissing is optimal expansion of the main vessel stent. And as you learned from the lecture of Dr. Milašinović, impact of the side branch diameter on discrepancy between proximal and distal part of main vessel is important, because diameter of the main vessel proximal is 2/3 of the sum of two distal vessel diameters. So in case that you have very small side branch, then there is really very small step down difference in diameter between proximal and distal part of the main vessel. In that case, you don't gain a lot by doing final kissing balloon, because discrepancy in diameters is small. Maybe just doing proximal optimization is sufficient. In large side branches, however, you have huge step down discrepancy in diameter between proximal and distal part of bifurcation. In that case, you need help of two overlap balloons to better expand the stent proximally. And again, we have 3-year improved follow-up if we do according to this principle final kissing balloon inflation. And the main vessel stent optimization part is important, because we in the first part say that POT should be routinely performed with short non-compliant balloon to correct for stent undersizing in the proximal main vessel. And of course, because we say that in red, routine final kissing balloon inflation is not recommended in provisional, because we don't have clinical evidence that doing kissing routinely, even in small side branch, will impact on clinical outcome of our patient. However, kissing balloon inflation with non-compliant balloons is important, because reduces angiographic complications and improves procedural success. And there is interplay between proximal optimization, final kissing balloon inflation, and use of non-compliant balloon. That interplay actually results in optimal main vessel stent expansion and better clinical outcome for our patients. So if you decide to do final kissing, you see that you have to remove the struts from the ostium of the side branch. You need to better open stent in the proximal part of the main vessel, and you actually create high shear stress area at the carina level, like in native bifurcation lesions. We recommend to use short non-compliant balloon, start inflation with side branch balloon first, and then main vessel balloon, and we recommend longer inflation times, 20 to 30 seconds. If patient does not tolerate long inflation, you can do 3 short inflations, 10 seconds each. So 3 times 10 equals, according to bench testing, 1 single inflation of 30 seconds. Final single balloon proximally, like second pot, is important, because by overlapping 2 balloons, you see that you create oval shape deformation of the proximal main vessel stent. And this oval shape, according to OCT data from Japanese study, is not good, because produces low shear stress areas and more progression of neointima in low shear stress areas. According to this recommendation, you should use the same pot balloon that you should use before. You should do it again at the end of the procedure. And there is recently, coming from France, alternative to final kissing, which is pot, side branch balloon inflation, and second pot. So you implant stent in the main vessel, you do pot as described. After pot, you exchange your wires, you use balloon open struts towards the side branch, and then you repeat second pot. The name of the technique is pot side pot, and you don't use 2 indeflators, so you can also save some money by using only 1 indeflator. Sometimes, and especially in bifurcations with large side branch and diffuse disease in the side branch, we plan 2 stents up front. And our consensus that large side branches with significant osteal disease extending further into the side branch are likely to require 2 stent strategy are tested in at least 2 randomized trials. One is Nordic Baltic 4, was presented at PCR in 2015 and did not show significant difference in MACE compared to provisional. And also European Bifurcation Club 2 study that was published in Eurointerventions 2016 did not find significant difference in clinical outcomes, but there was some difference in rate of repeat revascularization, which of course was higher with single stent strategy. If you decide to do 2 stent strategy according to randomized trials, any of TAP, culotte, or double kissing crush could be used because they have comparable clinical outcomes if a procedure is performed at the high technical level. And finally, should we stent always main vessel first? According to bench testing data and retrospective registry from Korea, no, we should stent actually more severe lesion first. So if you have very tight ostium of the diagonal and less severe disease in the LAD, and if you decide to use upfront 2 stent strategy, you can also start by stenting diagonal first. T and TAP are recommended for wide bifurcation angle. Culotte or double kissing crush are recommended for narrow bifurcation angle. And when performing 2 stent bifurcation PCI, we should try our best to finish procedure with final kissing, because not doing final kissing at the end increases the rate of stent thrombosis and impacts on clinical outcome of our patients. The role of imaging is also very important because it's a valuable supplement in bifurcation treatment, especially if you are treating complex lesions because of known limitations of angiography. It's strongly recommended for centers to have access to intravascular imaging, especially if they are trying to do complex interventions like left main PCI. And for left main bifurcation treatment, IVUS is strongly recommended, but also OCT can be used with the provision that ortho-osteal assessment is often very difficult. And wire positions in stent recrossing can be evaluated by OCT. So, dear young colleagues, I would like to conclude that provisional side branch stenting is recommended for majority of bifurcations. Proximal optimization is mandatory essential step for every procedure, and kissing balloon inflation is optional in provisional, but it's mandatory in 2 stent techniques. 2 stent strategies may be considered for large side branches with diffuse disease, and imaging and functional guidance are recommended for complex interventions. I thank you very much for your attention.
Thank you. Thank you very much. And I hope you are ready for the avalanche of questions.
Absolutely.
So, well, I already see at least 10.
This is quite a quick one, actually. It was just the practicality of doing the final kissing balloon inflation. I wasn't quite clear. You mentioned 12 atmosphere versus 4. Could you just go through how you would actually do it?
Yeah, so thanks for that question. I didn't have time to go in details, and I don't think for the fellows course it's so important the pressure to which you go. You really need to perform several procedures, gain some experience, and then take care of pressure. It's something that we brought from bench testing, that if you start by inflating side branch balloon first, you remove metal from the ostium of the side branch. And that's why we go to moderate pressure, 8, 10, 12, and then you start inflating main vessel balloon. Actually, your nerves start first with the side branch, then you start with the main vessel. You increase slowly pressure in the balloon in the main vessel, and you start decreasing slowly balloon in the side branch. So you go alternate, 12 in the side branch, 4 for the beginning in the main vessel, 6, but you should not be dogmatic. It's not 4 and you stop. You look at the screen, and when you see the balloon fully open, you can stop. And then you increase pressure in the main vessel to 12, you decrease pressure to 4 in the side branch, and you simultaneously deflate. So it's more important that there is a sequence, because you need, before the end of procedure, to have at least partial inflation of both balloons. The role of kissing is twofold. Main one is to open better stent in the proximal main vessel, but the second role of kissing is to put carina in the center, because by simultaneous inflation of two balloons, you reconstruct natural anatomy, as Dr. Milashinovic said. It's very important that you keep in mind that carina has to be in the center and divide flow. It's flow divider, divide flow in both branches.
When you're sizing the balloons for your final kiss, do you size on a 1-to-1 ratio based on the distal reference diameters of the vessels?
Exactly.
Thanks.
Just for the other colleagues in the room. So if you use, in previous case, 2.5 is size of diagonal, you take balloon 2.5, never bigger. If you put stent 3.0, you take stent 3.0 because of the distal. And then you go to these pressures, and of course, composition of the plaque, presence of calcium may impact on your decision. But in general, you want to see full inflation of both balloons and then simultaneous deflation.
How do you treat side branch, osteal side branch lesions without involving the main branch, particularly in lesions with angle is below 70 degrees?
Yeah, that's $1 million question. I mean, when you find out, you tell me, and I will do the same. It's very difficult to find one answer for all anatomies, but something that is really the widely accepted approach is the inverted provisional. You need to stand from the main vessel into the side branch, do proximal optimization, and open struts into the main vessel. Otherwise, you can never be precise, especially in situation that you described, narrow angle bifurcation 001.
Can you shed some light on the pot side pot that you talked about, please?
Yeah. So pot is a regular part of the procedure. Pot balloon can be either non-compliant or semi-compliant, depends on the length that is available, because you want to stay inside the stent in the proximal part of the main vessel. You inflate first time pot because you want to open struts according to reference diameter proximally. After that, you exchange the wires as you regularly do. Then you select semi-compliant or non-compliant balloon just to open access into the side branch. So the same in deflator, you just exchange, you use small balloon on the diagonal wire, open access in diagonal, remove and use second time the same balloon that you use for initial pot, and you repeat pot. Why you are doing pot twice? If you allow me to draw, maybe it's easier, but I can also try to explain. If you have stent in the main vessel, when you inflate balloon towards the side branch, in the direction of the side branch, you actually create deformation opposite to the orifice of the side branch, because you detach stent from the vessel wall. Yeah, exactly. You see, having balloon in this projection and inflating simply detaches stent from this point here. So you have some detachment and incomplete apposition exactly opposite to the ostium of the side branch. Hypothetically, this creates turbulence flow, this creates differences in shear stress, and as a consequence, you can have an nidus for thrombus formation. But we don't have it regularly documented. We just learn from bench testing what is not good in the bench testing. One day in the future will be shown not to be good, like crash in patients. So we use bench testing, decide what is not good, find solution, and then test again. And when we are happy with bench testing, we try to implement in patients.
Just one comment. What is very important with this issue, this is something what you will never see on the angiogram. In the angiogram, it will look excellent. You open the side branch, the main branch has a nice result because you never see the struts on the angiogram. We know, as you said, from bench, we know from OCT, the struts are hanging there. So at the end, if you just open the side branch, you jeopardize for your main branch for the sake of a side branch. So whatever you do in the side branch, opening a balloon whatsoever, the last step should be the procedure that you inflate a balloon in the main branch and you achieve the perfect result of the main branch because this is your main goal, to treat it perfectly.
Use the
Flip chart.
in this situation, or maybe I can use
Maybe we use another one.
yes, okay. This is fine. Only this is a case with side branch is something around 2.5 millimeter or 2.75 millimeter. Okay, a large side branch, no disease, nothing. So we decide the provisional stenting. And then we do everything perfectly. The stent is well opposed. It's a 3.5 millimeter. Okay, good result. Perfect. Pot. The pot is done. About the size of the balloon, you decided to open the strut. About the size of the balloon to open the strut, can you give information? Which balloon you will select?
Yeah.
And for which purpose?
Yeah, thank you very much. So there is a big debate about that. From idealistic selection of non-compliant balloon, adequately sized 1:1 with a reference diameter, non-compliant because by increasing pressure, you try not to expand too much diameter. In that case, it's one extreme. The other extreme is just to restore flow, so you intentionally use undersized balloon, and in that case, you can use semi-compliant or non-compliant balloon. So we don't have clinical evidence that selection of small, partially undersized has impact on clinical outcome.
Let me, I will try to, the design of the stent, it doesn't matter. No? You decided to open this strut. How large you can open this strut?
Yeah.
Because this is a question, you know, for example, I saw some case, even live demonstration, and then the operators take a 3 millimeter balloon. For which purpose?
Yeah. Again, it depends on which cell you actually wire. And unless you do OCT with online reconstruction to make sure that you are crossing distal cell, which is widely open, you cannot optimally open every single cell because of the number of connectors which define the surface area for each cell. For example, if this is the ostium of the side branch here, and if you wire this small cell, you will never be able to fully open even with a small balloon, not to talk about big balloon. So you need imaging if you want to be puristic, but in real life, opening with slightly undersized balloon to restore flow
For example,
is
2
millimeters
is enough.
is first safe, second will improve clinical outcome.